introduction. A very good morning to everyone. I feel happy to see such a houseful audience. My regards to the chairperson, faculties, and all seniors. So I am invited today and I'm thankful to the entire team of Diabetes India for giving me this opportunity to speak on this highly relevant topic, diabetes management in the elderly. So why is it important? I think diabetes management in all age groups is important, but when you're treating a population such as the elderly population, it is a comprehensive management. You're not just treating diabetes, you're treating a patient who has hypertension, who has dyslipidemia, who may be having a history of a stroke, a CVA, MI, and a lot of other dementia, cognitive decline. So there's a lot of things that you're treating at once. And now you can call this diabetes epidemic the graying diabetes epidemic, where you can see the numbers as striking as 136 million, which is predicted to be double in the next 20 years. In India, you can say almost 14% of Indians have diabetes, elderly diabetes, and urban versus rural, the numbers are quite biased. I feel it must be skewed because rural, we know they neglect their health, there's no screening, but in urban, because we have so many routine testing and screening for diabetes, the numbers are quite high in the urban population. So why diabetes is so common in the elderly? So it's a part of senescence, it's a part of the age-related pathophysiology where there's a decline in beta cell function. There is a blunted GLP-1, GIP-1 response, which makes it more important to prevent hypoglycemia in these patients. And most importantly, loss of muscle mass that leads to increase in a comparative increase in visceral fat, and which increases the insulin resistance in this population. If you talk about the assessment framework, as I said, it is comprehensive. So it has multiple domains: medical, functional, cognitive, social. You have to look at the comorbidities of the patient before you plan the treatment. And very importantly, as we are all talking about, it's a tailor-made approach and a personalized care for the patient. So if you talk about the glycemic targets for ADA framework, yes, the status is the framework is based on the health status of the patient. If it's a healthy patient, the A1C is around 7.5, the target is 7.5 with the TIR more than 70%. Intermediate health status, then less than 8 is okay. In frail patient, it's more important to focus on hypoglycemia or other symptoms. If you talk about the guidelines, the different guidelines, mostly what you can see is the targets are flexible. It is very much based on the health status of the patient. Now I spoke about ADA, and the other guidelines like Diabetes Canada similarly depends on the functionality of the patient. End of life A1C is not recommended by DC. By the IDF, you can see end of life, the only target is prevent symptomatic hyperglycemia, which obviously means that you also have to prevent hypoglycemia. As per the NICE guidelines, the standard target is around 6.5 to 7 for good functionality patients, and explicitly recommends relaxing targets in older and frail adults, especially those with high hypoglycemia risk, limited life expectancy, or multiple morbidities. Yes, you have to keep in mind the limitations of testing A1C. Because in elderly, you have these comorbidities like anemia, CKD, or some history of recent transfusions. You can consider CGM metric. CGM is obviously, it will be very helpful in this patient. So if possible, that should always be preferred, or consider other markers like fructosamine, and always interpret A1C contextually. That is very important. In older adults, as I said, CGM will be very helpful. It can help to detect unrecognized hypoglycemia, and also those patients with cognitive decline or dementia. In these patients, it will be useful for a CGM. Now, chronic complication screening also, it's important that it's more symptom driven rather than protocol driven. You adapt the screening based on life expectancy and functional status of the patient. If you talk about hypertension management, so the ADA guidelines mention the cutoff as 140 by 80. You can relax it to 150 by 90 millimeters of mercury in very complex or poor health situations. For the Diabetes Canada, it's 130 by 80 if fit and long life expectancy. You don't want to increase the risk of falls. So the blood pressure guidelines are quite relaxed. And in frail patients, you can relax it to 150 by 90 millimeters of mercury. So as per NICE, there's no age specific BP target. It emphasizes on individualization and avoidance of overtreatment, especially in these frail adults. For lipid management, if the patient 40 to 75 statins as per risk. If age is more than 75 years, then if the patient is already on statin and is tolerating it well, you can continue it, and consider initiating a moderate intensity if there's ASCVD risk and life expectancy is reasonable. And always be cautious of polypharmacy, which we discussed in detail, and frailty and drug interactions. So the targets, if you see the guidelines for ADA, the target is in very high CV risk, less than 70. For DC, it's 77 or 50% reduction from baseline. IDF is also 77, CV risk adjusted. And NICE also does not mandate a numeric LDL target, especially in older or frail adults. So as we discussed, start low, go slow, and minimize the pill burden, avoid drugs with high hypoglycemia risk, and renal dose adjustment as required. For drug-to-drug summary, metformin is preferable if the patient is tolerating it well and renal function is normal. You should monitor the renal function and B12. DPP-4 inhibitors are well tolerated and a good choice in these patients. Sulfonylureas avoid as much as possible, but if required and patient is tolerating, you can still give sulfonylureas. Same goes for insulin as well. And SGLT2, there are definite benefits, but caution with hydration and UTI. As we know, cystopathy is common, recurrent UTIs are common, so it should be kept in mind. Now, GLP-1 RA you can use in obese and CVD, but you must watch for GI side effects. Thiazolidinediones, there is a risk of fluid retention and of course fracture risk, so you can use in some selected patients, but be careful of its use. For insulin, try to avoid complex regimens. If possible, a once daily basal insulin is preferable with other drugs that do not have a hypoglycemia risk, and simplify the regimen as much as possible. And this goes without saying, use pens for easier delivery. Now, in elderly, in patients, because they are at high risk of hypoglycemia, because the counter-regulatory mechanisms are also blunted, so one should be careful about hypoglycemia because symptoms may be masked or blunted. Polypharmacy, CKD, erratic meal timings, this can increase the risk of hypoglycemia, and hypoglycemia itself will increase the risk of falls, confusion, cognitive decline, and increase the morbidity as a whole. So as I said, we need to relax targets. Targets should be highly individualized for each patient. Use drugs which have a lower hypoglycemia risk and avoid drugs that can increase the risk of hypoglycemia. So nutrition is also important and we should not restrict the nutrition. Try to make an adequate nutrition plan for this patient. Individualized management at the first visit, maybe a nutritionist consultation would also help. And physical activity in those patients who are capable, definitely you can aim for a 150 minute per week aerobic activity. Very important to include resistance and balance training. Resistance training to combat sarcopenia, balance training for to reduce the risk of falls and also bone health, and adapt to mobility and comorbidities. So frailty and falls, sarcopenia increases this risk, especially with if the patient has concomitant neuropathy and CKD. So falls again linked to hypoglycemia, visual impairment, and orthostatic hypotension. Fall prevention strategies are essential. You can do a quick screening for sarcopenia with the frail questionnaire, and a detailed screening can be done with the SARC-F. So as I said, the two most important strategies for sarcopenia management is progressive resistance training, supported training, and protein supplementation. With that, obviously ancillary vitamin D and nutritional optimization is important. The pharmacological options are still investigational, so we've not tried this as much. We rely much more on muscle training and nutritional support, and it's important to address certain underlying contributors. Like you have to obviously optimize the diabetes control as per the patient's target, review the medications that the patient is on, manage other comorbidities like depression, inactivity, or comorbid illness. So cognitive impairment, we have a session next on dementia, so I'll not go much into that, but you can use minicog or mocha for screening. For a quick screening, you can use a minicog where a 3-word recall or a clock drawing test, you can do that. Or for a detailed one, you have Montreal cognitive assessment. I think at the first visit and maybe 6 monthly, we can screen for these markers of cognitive decline. So geriatric syndromes are also associated with depression, and depression again will lead to poor adherence to medication, poor diet, and poor glycemic control. So diabetes distress and burnout is common in elderly, especially those with lack of social support. So it's quite common. And other conditions, also chronic pain due to conditions like neuropathy, painful neuropathy, or osteoarthritis can also add to this depression. Now, screening, there are some quick screening tools, simply just asking the patient a few questions. And also there are some detailed screening tools that can help to diagnose this in the elderly. So it is a condition that should be treated. It is not just, yes, somebody is depressed, motivate the person. So apart from that, yes, you need to take an active stance on it. Psychotherapy like CBT or problem solving therapies if available. Physical activity also, it helps to some extent to, regulate the mood, and also as much as helpful for glycemic control. Social engagement for a patient who is able to do that, and refer to a mental health professional if possible. So some drugs which it is actually difficult to prescribe antidepressants in elderly, so one should be careful because of polypharmacy, pharmacy, drug interactions, adverse effects. So few drugs are quite not that safe, but safer, I would say safer alternatives. So that should be kept in mind. If required, you can start at a low dose. So for long-term care, targets are relaxed. It is individualized. That will be my most important point on glycemic goals. We should simplify the regimens and train the long-term staff for safe monitoring and management of these patients. So overall, I would say that there are important points. The glycemic goals should be tailored. Hypertension control should be relaxed, and the targets again should be individualized. Lipid management is again individualized. Dementia at least screen annually, and encourage movement. Sarcopenia management is quite neglected, and I think that is very important, especially in these patients. And so this is a summary of all the targets that I have discussed in my slide. And with that, I would end my presentation, and I would thank all of you for your patient hearing.